Hello, everyone, and welcome into Senior Living Live. My name is Melissa. As always, thank you so much for being with us. We've got an amazing webinar on tap today, Planning for the Road Ahead, Dementia Care and Brain Health. Now, as we age, concerns about brain health continue to increase, but what are we all doing about it? That's the big question. We're going to talk about that here today. Studies find that seniors may be reluctant to have this conversation with their healthcare providers. If this is you, and it might very well be, we've got a perfect opportunity to share some important information you may not know about brain health. And also, you'll have the ability to ask our host, Dr. Keith Yoder, you see him there, questions you may be putting off or discuss issues you may need a little bit more clarity about. In order to be a part of our conversation, as always, guys, if you've been a part of these webinars before, you know what to do. If not, I'm going to tell you right now. You can scroll down to the bottom of your screen where it says Q&A. Feel free to type your questions out there at any point in time during Dr. Yoder's presentation, and we will be happy to get those read to him towards the back end of the webinar, which we expect to last about an hour. Dr. Yoder, thank you so much for taking your important time to be with us here today. We are so appreciative, very much looking forward to hearing you speak. The webinar is all yours.
Thanks, Melissa. I'm excited to be here. Thanks again to Arbor for inviting Spark down to talk. So I'm going to bring up my slides. And as Melissa said, I'm Keith Yoder. I have a PhD in cognitive neuroscience. I work at a company called SPARK Neuro. I am the Director of Research and Development there, and I'm also the primary investigator on 2 NIH grants that we are using to fund research into ways we can help individuals understand their cognitive health and make good plans for the future. So today I'm going to be talking about dementia care and brain health. Now, first, I want to talk, just in case anyone isn't sure, what exactly is dementia? So dementia is an umbrella term for loss of memory and other thinking abilities that are severe enough to interfere with daily life. Now, we all forget things as we get older. Where did I put my keys? What was the name of that actress in that movie? That's a normal part of aging. But when we're talking about dementia, we're talking about memory loss that's severe enough to interfere with daily life. And there are different types of dementia. Now, the most common is Alzheimer's disease. Alzheimer's disease is a specific pair of proteins that get disrupted in our brain. You may hear about amyloid or A beta, and the other protein is tau. Another type of dementia is vascular dementia. That has to do with blood vessels being disrupted. Then there's Lewy body dementia. There's a protein alpha-synuclein that's disrupted. There's frontotemporal dementia. There's also dementia that can happen after severe brain injury. Other conditions like Huntington's can lead to dementia. And mixed dementia then is a kind of dementia that is from more than one cause. So sometimes people have Lewy body disease and Alzheimer's disease as the cause for dementia, but over 70% of dementia cases are from Alzheimer's disease. Now, the primary warning sign of dementia is change. You want to watch for changes that occur over a few years, things like memory changes that disrupt life, problems with familiar tasks, or social or mood changes. And again, these are changes over a few years. If you're in your 40s and you're not quite as fast at some games as you were in your 20s, that's nothing to be concerned about. On the other hand, if you're noticing memory problems in yourself or someone else that suddenly manifest over a couple days or a week, that may be a sign that there's something seriously wrong and you want to talk to a medical professional quickly. But when we're talking about dementia, we're looking for changes in memory that occur over a few years. Those sorts of problems with familiar tasks are like someone used to bake all the time, but now they don't remember how to follow a recipe that they've made hundreds, if not thousands of times. Now, we are learning more and more every day about what causes dementia, but also what are risk factors. And so I'm going to talk a little bit later, but I want to give you a preview about what are things that I can do about dementia. What are things I can do to keep my brain healthy? There used to be 12, but last year the Lancet Commission released 2 more, so there are now 14 risk factors. This Lancet Dementia report that has dug into what we call modifiable risk factors. So these are not things like your genetics, where you're born this way, we don't have ways to change your DNA, but we have ways of changing these risk factors. And modifying these 14 risk factors can prevent or at least delay up to 45% of dementia cases. So this graphic's a little complicated, but it's showing that early in life, one of the biggest risk factors is having less education. But then there are things in midlife and things in late life. Some of the bigger ones are actually hearing loss in midlife is a big risk factor for dementia later in life, especially if it's not treated with things like hearing aids or other kinds of accommodations. One of the new ones that was introduced in the most recent report is high LDL cholesterol. So high cholesterol has been now uniquely linked. And I should dig in just briefly. These numbers here represent, so this 7% hearing loss indicates that in these big meta-analysis studies, that if we compare people where we carefully controlled everything else, people who have hearing loss that's not treated compared to people who don't, 7% of dementia cases overall could be reduced if we had intervened and dealt with hearing loss in midlife. But there are things even now in later life, if we're talking about someone 65 and older, maybe someone who's retired, there are still things that we can target to reduce risk of developing dementia and delaying cognitive decline. These include things like stopping smoking, managing depression, dealing with social isolation, making sure we maintain physical active lifestyles, maintaining treatments and managing diabetes, managing reduced air pollution, so air filters, changing your filter in your HVAC, as well as vision loss. So sometimes, and this is one of the more recent ones that's been identified, people might think, oh, this person's having problems driving, maybe there's something going on cognitively, or maybe they just need a better prescription. They haven't needed glasses before, and now they do, and that'll help them see street signs better than they could before. So if we think about Florida, this is a report released just last year from the Alzheimer's Association, looking at how some risk factors show up in adults in Florida, so specifically. So if we look at midlife hypertension, so this is high blood pressure, adults aged 45 to 65, 35.9%, almost 40% of adults 45 to 64 in Florida have hypertension, which is an increase, which will increase the risk of dementia. Similarly, 40% of adults in Florida have physical inactivity, 37% have obesity in midlife, some less common ones, diabetes at 12%. And this is just if we ask 100 people off the street in Florida, how many of them would show one of these risk factors. And there's been interesting social determinants of health work coming out to suggest that different risk profiles may be different in different racial groups. So we can see here that Black Americans living in Florida are more likely to have at least one of these risk factors, not counting poor sleep, than, for instance, white Americans. So these are things we're really trying to dig in as a medical community to understand what are things that are increasing the risk of dementia and where are places where we might be missing care gaps. So the other part of the talk today is about dementia care planning. You might not know what a care plan is. Well, a care plan is a collaborative document that reviews pertinent healthcare information for medical conditions. It's a way to organize and document a plan of care to approach health conditions in a proactive manner. It's collaborative because this will happen in a conversation, maybe an hour with your primary care doctor or a nurse practitioner, but a medical professional will sit down and do a thorough conversation to document lots of different ways to understand what's happening in someone in a medical context. Then we organize all of these details into a written document that then can be handed over to a patient or a caregiver or a primary care physician so that we can understand what are steps that we can take proactively to maintain and improve health. Now, the purpose of a dementia care plan then is to provide a structured, ongoing support for the patient and the caregiver. We want to make sure that we address medical, functional, emotional, and safety needs. And this allows us to connect patients and families to resources and services. So the first part of a dementia care planning visit is going to involve looking at a dementia evaluation. So the core components of a dementia evaluation are going to start with cognition-focused evaluations. This will be a history, both your own history as well as family members' history, a brief exam, including some cognitive testing. We'll use standardized tools. These are some abbreviations. There's the mini mental state exam, or the MMSC. Then there's an 8-item informant interview that's designed to differentiate normal aging from dementia, or the AD8. When I say informant, that means the doctor might want to talk to the caregiver, so a spouse, a child, a close friend. And then finally, in a dementia care planning visit, we'll use an instrument that's called the FAST, which is a functional assessment staging tool that allows us to stage dementia. When we talk about staging, is there no evidence of cognitive decline, so a very low number, or are there good indications that dementia is interfering with particular kinds of daily livings? So maybe problems getting dressed, problems cooking, those are different stages that we can use to communicate among clinicians very quickly about the disease progression. I mentioned daily activities, and so this is what we want to assess using a functional assessment. So there's an activities of daily living instrument that we'll use, or ADL. There's also the IADL for informants, where we want to look at how our normal daily activities going, getting dressed, driving to the store, getting groceries, these sorts of things. And we want to also include then decision-making capacity. Is someone making good financial decisions? Are they correctly identifying spam emails, those sorts of things? And then we also want to make sure that we take into account medical workups. So this could be labs or imaging and evaluations for other contributors. So we want to make sure that we rule out other conditions that might be going wrong. If there's some dietary change that can be made to reduce some inflammation, those are things we want to take into account. When we talk about labs and imaging, there are now blood tests available that can test for those proteins I mentioned at the start of the talk, that there are blood tests to look at amyloid levels and tau levels that are a really good estimate of what those proteins might be in the brain. This is really sort of breakthrough technology in the last decade. Previously, if we wanted to look at amyloid in the brain, you would have to get something called a positron emission tomography scan, or PET scan, which uses radioactive chemicals to identify specific sections in the brain. It's sort of expensive and time-consuming. The alternative is a lumbar puncture to look at cerebrospinal fluid, or CSF, which is an uncomfortable procedure, but lets us look at proteins in the fluid that fills the brain. But overall, the point of a dementia care planning visit, when we're thinking about dementia, is that we want an evaluation to identify the dementia stage. So is it not present? Is it mild? Is it moderate, severe? As well as the source of pathology. So what is the cause of dementia? So those blood tests or other kind of imaging tests can help us understand, is this frontotemporal? Is this Lewy body? Is this Alzheimer's? What's the underlying cause? Because the cause will help us look at what our good options might be for treatment. So the second part of a care planning visit, and this is whether we're focused on dementia or not, will be a medication and health review. This involves medication reconciliation, where we'll want to check for any interactions that might be happening on current medications. And also we want to evaluate adherence issues. So if you're on diabetes medication, we want to make sure that you're taking your metformin at the right dosage and at the right times. We also want to review high-risk medications. So if someone's on a sedative or anticholinergics, which are sort of designed to look at the acetylcholine system, we want to make sure that those are being adhered to correctly and that we've made sure that the dosage is correct for those. We also want to consider dementia-specific treatments. So there are cholinesterase inhibitors, which is a class of drugs that many people find helps improve memory performance in people who are starting to experience accelerated decline that could be indicative of dementia. There are also some brand new treatments available. You may have heard of aducanumab or lecanemab. That MAB is a monoclonal antibody, it's a monthly treatment where you get an infusion of antibodies that help target amyloid in the brain, that these antibodies sort of explain to your immune system, amyloid in the brain should go, and it treats that like an infection. These are really cutting edge treatments. There are new ones coming out, and the hope and expectation based on ongoing clinical trials is we should soon have treatments that can also target tau, the other protein that's disrupted and pathological in Alzheimer's disease. So as we consider these treatments, we then also want to address coexisting conditions. Again, diabetes, hypertension, hearing or vision loss. We want to make sure we get a complete picture of the patient. Next, we also want to look at neuropsychiatric and behavioral symptoms. So we'll want to screen for depression, anxiety, and sleep disturbances. These might be questionnaires, these might be interviews with the caregiver. We want to evaluate agitation, aggression, psychosis, withdrawal. Each of these could be indications of things that are going wrong that are leading to dementia. Some might appear individually or they might co-occur. We want to use standardized instruments for symptom monitoring. So care planning visits can happen multiple times. That's sort of the idea. We want to keep this ongoing, this active conversation between the clinician, the patient, and the caregiver. And we'll also discuss different treatment options. So for depression or anxiety, maybe a selective serotonin reuptake inhibitor or SSRI, some kind of medication. Or we might also want to look at behavioral strategies. Next, we also want to talk about safety and independence. Again, the point of a care planning visit is to try to get a holistic picture of the patient and talk about holistic strategies that we can have best possible outcomes going forward. One is home safety. So things like fall risks, wandering, emergency planning, if there's an option to move to a place that doesn't have as many stairs, those are sort of options that are discussed. Sometimes there are opportunities to install new equipment to make it easier. Adding handrails to stairs can help decrease fall risks. Adding ramps for small stairs, similarly. Driving safety is also important, so we want to assess readiness to stop driving if that's on the horizon. And the point is not to make a determination immediately to sort of take someone's keys away unless there's an urgent risk. It's about developing sort of timelines. That's having these conversations early can really help sort of set the stage so that there can be a lot of time to think through and sort of take a comfortable pace as we navigate sort of thinking what the future might be. And the goal here is always to support independence where possible. Just as I said, we want to try to evaluate what is safe and how can we maintain safety while maintaining independence. We also importantly want to include caregiver and social support during this care planning visit. So we want to identify caregivers and support networks. So this could be adult children, this could be spouses, this could be other friends or neighbors who are around. We want to make sure that we take time to assess the caregiver knowledge, any needs, and their readiness. So educational materials are almost always included as part of a care plan, where additional resources that someone might use to go and try to learn more about a condition, to get connected with resources in the community. This is like we want to provide education and training for daily tasks. If you have to help someone with their medication, we want to make sure that process is comfortable. And the point is to sort of increase knowledge, establish routines, decrease anxiety around these situations. We can do this by connecting to respite care, support groups, community resources. So being aware of where are you located geographically, what options are available. So Tampa compared to Miami, compared to Fort Lauderdale, looking at what's available for you that would be easy and accessible where you in that context is the caregiver. Um, because again, the point is to maintain this holistic communal approach to creating this care plan. We also want to take a look towards the future, including advanced and future planning. So we want to make sure that we take time to discuss advanced directives, including do not resuscitate or DNR, or do not intubate, DNI preferences, so that people can decide ahead of time what they would like in certain circumstances. In the same way, we want to establish financial and healthcare power of attorney, and we want to encourage early planning to reduce caregiver stress. We make these decisions now. There may be a little bit of anxiety about trying to think about these conversations, but the point is to think carefully about what we would like the future to hold and to carefully articulate those in written forms so that any legal things can be cleared. We can get all of the signatures in place so that in the event that we need to rely on power of attorney or some medical event happens, the decisions have already been made. Now, the final part of the dementia care plan is that then the clinician will develop a written care plan. So this involves summarizing findings, any diagnosis and staging. This all gets documented into one place so that we can consolidate everything that's happened during this sort of collaborative conversation. That we want to document any treatment strategies that we've described, whether those are medical strategies like changing medications, adding medications, adjusting and working to think through whether the current medications are correct for the situation, any behavioral strategies. So these could be as simple as helping develop an exercise plan. We're going to try to walk for 30 minutes every other day. And they can also be functional strategies about rearranging the house so that things are easier to navigate. We want to include the caregiver support and resource materials. So as I mentioned before, the written care plan will include links and phone numbers and external resources that can be used so that the caregiver feels support in the situation as well. And importantly, the care plan should be updated regularly with progression of the disease. So something like Alzheimer's, you would expect at least once a year to have this visit. Again, in the modern world, these can happen as telehealth appointments. So we could set up, and rather than a webinar, we'd have sort of a direct one-on-one talk, maybe with the caregiver present often, to go through and spend maybe an hour to really make sure that we've taken a thorough review of the situation to provide resources and make decisions about the future. Now, Medicare does cover annual cognitive assessments and care planning visits. Sometimes those happen at the same time, sometimes those happen at different times. You can go to alz.org, which is the Alzheimer's Association's website. And if you look for their care planning visit page, they have a lot of details there. Now, as the name suggests, Alzheimer's Association focuses a lot on Alzheimer's disease specifically, but they have a lot of resources available for any kind of dementia. So anyone worried about memory concerns, you can find lots of useful details there. Now, so our key takeaway then for caregivers, maybe you're not experiencing memory problems, but you have a close friend or family member who is, the takeaway for you is that dementia care in these care planning visits is comprehensive and evolving. As I've mentioned, we have new techniques for looking at medical assessments of someone's protein levels. There are also new disease modifying drugs on the market with new ones in the pipeline. We want to focus on cognition, function, safety, and quality of life. You've heard me use the word holistic a lot because that really is the point of these care plans. And caregiver involvement is central to success. The point is to work together in the social context with social support to maximize success. And then the written care plan serves as the roadmap for both the patient and the family. Now, now that we've sort of talked through what care plans are, the last part of my talk is going to be about managing risk. So you may ask, what can I do? What can I do about my cognitive health right now? So I want to talk through more closely some of those modifiable risk factors. First, we want to try to control blood pressure. So ideally, your systolic blood pressure should be less than 130 millimeters of mercury. That systolic is that top number. When you get your blood pressure, you've got systolic over diastolic. You want that top number to be low. Sometimes changes in diet and exercise are enough to control that. Sometimes medications are necessary for that. And you can work with your primary care physician to help find the right balance for you to keep that blood pressure low and in check. The same way, we want to manage diabetes with treatment and lifestyle changes. So my father just is on the cusp of retiring and has also just gotten his diabetes diagnosis, and so is working on a lot of sort of life changes to adapt. He's changing his diet, changing the kind of bread that he has, the sorts of things he doesn't eat, monitoring his glucose, and is doing really well. But these sorts of like management things happen with regular communication with your doctor or your nurse practitioner to help understand what your blood glucose does. Do you need to change the order in which you eat your food? He's found it really useful to eat the protein at the start of the meal instead of the end of the meal. Now, along with that, we also want to maintain a healthy weight with a balanced diet and activity. Actually, the Alzheimer's Association, if you want to summarize what's the best way to protect your brain health, is to stay active. This is stay active mentally, stay active physically, stay active socially. But being obese is an increased risk factor. And so keeping a healthy weight, which is maintained with a balanced diet and regular activity, is a great way that you can start changing your lifestyle right now to improve your chances of maintaining cognitive health. Now, we also want to make sure that folks avoid smoking and secondhand smoke, that quitting is beneficial even in later years. It's never too late to stop smoking. The benefits are better in terms of what we see in the literature if that happens earlier, but it's never too late. And then it's important to limit alcohol to safe levels. So, what are safe levels? Well, when we look in the literature as scientists about excessive drinking being a risk factor for later cognitive decline, we're talking about more than 20 units of alcohol a week, where a unit of alcohol is a shot. So, like 25 milliliters of an 80 proof spirit. 2 units would be a pint of beer or a glass of wine. And here, so 175 milliliters of wine with 12% alcohol by volume. This would maybe be sort of a classic glass of red wine. So you'll notice if you do the math, maybe 2 units, a glass of red wine a day is about 14 units, 15 if we round up, which is in the range of safe alcohol level. So if you're following a diet, especially if your doctor has recommended some red wine in your diet, maybe for antioxidants, that would be consistent with the Alzheimer's Association and a lot of dementia research in terms of what's a safe level of alcohol consumption. However, I do have to add that there is some evidence that no alcohol is beneficial, that the small benefits you do get are not outweighed by the negative consequences of the changes that alcohol leads to in blood flow in particular. This is sort of a minority of studies, but there is this sort of growing movement. There's a little bit of controversy in the field right now, but the official recommendation is to limit alcohol to less than 21 units per week. Now, managing risks also, I want to talk about additional later life opportunities. These are sort of things that for sure anybody who's retired can absolutely take advantage of and think about in terms of taking control of managing your risk for cognitive decline. The first is to stay socially connected. Social isolation is a significant risk factor for cognitive decline and dementia. So these social connections can be with friends, these are people who are neighbors or people who you keep in touch with over the phone or letters if you're one of the folks who still do that. I still like sending and receiving cards. They can be family members, so siblings, children, distant cousins that you still keep in touch with, or folks in the community that you may not necessarily call friends, but people who you see who are available to lend an ear or help around if there's anything that you need. As I mentioned, staying physically active is super important. Regular exercise, where exercise doesn't have to mean going to the gym and doing hundreds of jumping jacks or lifting heavy, heavy weights. Walking is sufficient, just things that keep you moving. Gardening, building models, and these sorts of just staying active and not just sitting all day is a great way to avoid that risk of a sedentary lifestyle. Also, staying mentally active is important. So reading books, doing puzzles, learning new skills, could be working on models, doing crosswords. You'll notice some of these can be combined too. So you could do puzzles by yourself, or you could do puzzles with friends. You could listen to books while you walk, and that could be both reading and regular exercise. But doing things in community helps sort of work all of these together to building a vibrant lifestyle that can help maintain cognitive health. We talked about vision, but also using hearing aids if hearing is reduced. Part of the reason someone might be struggling with a game that they used to be really good at, maybe someone used to play bridge all the time, but now they're having to ask 3 or 4 times what Trump was again. Well, it may be just that the hearing has been reduced, and a hearing aid will help that a lot. My father-in-law resisted getting hearing aids for a long time, and once he got them, realized how much easier it was to be out in crowded restaurants. He didn't have to ask people to repeat things. And so looking at other underlying causes of discomfort are really helpful at mitigating the risks of future cognitive decline. Finally, sorry, not finally, but managing chronic conditions is important. We've talked about diabetes, hypertension, obesity, keeping these in check, and regularly communicating with your primary care physician or nurse practitioners, other medical professionals is important. And creating a safe environment to avoid falls and head injuries is also incredibly important. Avoiding falls, we talked about installing handrails, being in physical spaces that don't require lots of steps can help, but also avoiding head injuries. The Alzheimer's Association rightfully recommends wearing a helmet if you're doing things like riding bikes or more exciting sports like motorcycles, where head injuries might be common. Taking care to protect your head is very important. And finally, reducing exposure to indoor and outdoor air pollution. This could be avoiding secondhand smoke. Could also be making sure that you're regularly changing out the air filters in your HVAC system or living somewhere where there are folks who take care to do that for you. But making sure that your air quality is clean so that the oxygen and the systems that our bodies use to keep our brains healthy have the best shot at doing that. So our key takeaways from managing risk is that it's never too early or too late to reduce dementia risk. Small daily changes can add up. That a focus on heart health, brain stimulation, safety, and social connections is what we can think about if we want sort of just a couple of points to remember about how are we supposed to really make changes. And finally, caregivers can help by encouraging and supporting these habits. Now, before we stop for questions, I do want to tell you about an opportunity so that you could help impact the science of brain health. If you're between the ages of 65 and 95, you might be eligible to participate in the Remind V clinical study. That's one of the clinical studies where I'm the primary investigator. The Remind V study aims to evaluate investigational software innovations in brain health monitoring technology. Whether you have normal thinking or mild memory challenges, your participation will help improve the way doctors assess and manage cognitive health. What you can expect is a single 1.5 hour visit in the comfort of your home. We'll do 2 standardized cognitive assessments and then a 20-minute non-invasive EEG scan, a standard blood draw, and a $150 Amazon gift card for you and $25 for your support person. Please note, this study does not involve any experimentation, any experimental medications or procedures. I want to talk just briefly about this non-invasive EEG scan. EEG is electroencephalography, which is electrical signals measured at the head. Our setup looks like this. This is a cap. Each of these little white dots has a small little electrode sitting in it. The electrode doesn't touch your skin. We put a little bit of gel to make a little connection to the skin, so there'd be some gel there. And you may qualify if you are 65 to 95 years old, if you have a person in your life who spends at least 2 hours a week with you and is willing to answer a few questions, and if you have either normal thinking or some cognitive challenges. You can help impact the science of brain health if you want to participate in this. Some disclaimers that I have to disclose. This study was approved by the WCG IRB. That means an institutional review board reviewed all of our materials and study procedures to make sure that we are conducting ourselves with good research practices and good research ethics. The study is registered at clinicaltrials.gov, so we have reporting requirements to the federal government. And all of the work is fully funded by the National Institutes of Aging, which is one of the National Institutes of Health. This is our grant number and the $1.3 million grant for this 2-year project. This content is solely the responsibility of the authors, that's me, and does not necessarily represent the official views of the National Institutes of Health. Your privacy and data will be protected throughout participation, and if you're interested, you can email us at info@sparkneuro.com. That's info@sparkneuro.com. And thank you again for giving me some time to come and talk a little bit about care planning and dementia risk mitigation, and I'm happy to take any questions that you might have.
Very succinct, lots of information there. And I do have some questions, but I'm going to let our audience know that this is a good time, if you have any questions for Dr. Yoder, to get those in. And again, in order to do that, be a part of the conversation, just scroll down to the bottom of your screen where you see that little Q&A button. Click on it, type out your questions there, and I'm happy to read those to Dr. Yoder between now and the top of the hour. So thank you for all of that. Let's just start with the study first, because that's the
Mhm.
most recent thing that we saw. Where is there a specific location that is being conducted?
Oh, yeah, I should have mentioned. Let me go back briefly. The idea is that we will come to you. So it's in the comfort of your own home. We work to set up a time and have, we call it mobile technicians or examiners who will come and do this in your home.
And when you say in your home, is this limited to specific locations across the country?
So we're starting first in Florida. We've worked with folks who are in the Tampa area and in the Fort Lauderdale area primarily. If you email us, we can help determine if you're in one of our regions of service.
Okay, fantastic. And have you had any studies like this previously? Anything similar to this, and how did it turn out?
Yeah, that's a great question. So the V in Remind V is for validation. We had a previous study that was just Remind, where we worked with clinical sites in 12 different states, I think, across the US, where we used our EEG system to collect data from people who had different levels of cognitive impairment, some folks who were not impaired, some folks who were mildly impaired, we call it mild cognitive impairment, and then some individuals with dementia. We used that data, especially the EEG data and those cognitive tests, to then train a machine learning model to look at someone's EEG and predict whether they were cognitively impaired or not. And so this Remind V is to validate that algorithm. So we see good performance. We see that it's performing better than primary care physicians generally do at identifying dementia in terms of their regular rates of diagnosis. And so this Remind V study is helping us validate that algorithm, ultimately with the goal of being able to submit that to the FDA as what's called a software as a medical device.
Got it. So, with all the research you have done here, and this is, it's a loaded question. How much closer are we to coming into something that will, what maybe cure or halt or really slow the progression of dementia?
Yeah, that's a great question. And obviously that's sort of right the goal of all of this science is to how can we cure or stop the progression. Um, the we're sort of at a really exciting time that there are other good disease modifying drugs in the pipeline right now. So by disease modifying, I mean there are our current treatments for dementia include acetylcholinesterase inhibitors, which sort of treat the symptoms but not the disease. These like lecanemab is a disease modifying drug that actually removes amyloid from the brain. That has had some success. We have good reason to believe, though, that tau in particular is a protein that would be better to clear in terms of improving outcomes, and there are tau targeting therapies in clinical trial right now. So there are the optimistic view is that in 10 years this may be something more like skin cancer or pancreatic cancer, where we have really high survival rates and have a good sense of exactly where to intervene to disrupt the disease process. So this is this is an exciting time. 5 years ago we didn't have disease modifying treatments, and we do now.
Great. And for those of us who are not in this realm like you are, people are, we look at it and usually you go about your day until somebody you know or in love is affected by it, or until you're affected by it. And then all of a sudden it's like, well, what have we been doing this whole time? Can you take us through what has to transpire for something to come across the market, to come across your desk in research, to get in through the FDA and to get basically approved to get out to the consumers and the general public? How long does that process take? I imagine it's quite a bit of time.
Yeah, so that's a great question again. In terms of how sort of like the ideas are generated, is that's the work of like what we call basic science. So people working in labs, often at universities, sort of like really digging in deeply to try to understand, including non-human animal models of the disease, looking at how we can understand from rodents, for instance, how these different cellular processes work on timelines that are much faster. In terms of FDA approval, that does tend to take years, in part where there's a lot of care taken, especially with experimental drugs. There's sort of a variety of stages that you can get through, but ultimately the goal will be to have a clinical trial where there's careful control and with human subjects research, and that's sort of the gold standard. That after all of the care has been taken to make sure it is safe, then you'll need a phase 2 clinical trial that evaluates whether the drug that you or therapy or whatever you're intending to do is both safe and effective. And so those do tend to take years. Sort of a 2-year turnaround would be very quick. In part because often it's very difficult to make sure that you are doing all the things that you have to do to make sure that it's safe and you're meeting all of your obligations there.
Got it. And then, we'll kind of leave this sort of clinical spot of the discussion after this question. Is there anything in the pipeline that kind of that you've been discussing that should be, top of mind or should get people excited about all the research that has been done over the last couple of decades?
I mean, I think the work of the big pharmaceutical companies like Eli Lilly, for instance, has been working really hard on these disease modifying drugs. I think the like when they're successful, they're a big enough deal that like there's big press releases around them. So like if folks want to set up like a Google alert for Alzheimer's drug, that for sure would catch any of the big announcements if the FDA moves forward with approvals.
Got it. Okay, fantastic. Thank you for all that. So I want to go back to hearing loss, and I just want to make sure that that I understand correctly, and maybe the rest of our viewers understand. You mentioned at the very beginning, you looked at all the
Hmm.
percentages of things that affect, um, you know, uh,
Let's find that.
memory loss, and hearing loss is
Hmm.
one of them. Am I to assume that the hearing loss issue, as you said, it's something that could be fixed? Okay, yes, with hearing aids, what have you. But if somebody's sitting in there maybe in their 50s, their 60s, and they were maybe, love concerts and loud music, and they're like, oh my goodness, I know I have hearing loss. When you say fixing that, is that in essence to allow people to not become isolated? Which is again another risk factor for dementia. Can you talk about the hearing loss and kind of how that all ties in?
Yeah, I mean that's another really good question. So often when we think about like hearing loss, for sure social isolation would be a negative consequence of that. Like if you're having a hard time following conversations, you're less likely to go and engage, you're not getting as much enjoyment out of it. Importantly, when so the way these studies work, social isolation is sort of a separate, like a 5% reduction. If people weren't experiencing social isolation, they'd have a 5% lower chance of dementia. That's independent of hearing loss. So this is specifically about untreated hearing loss being a separate independent contributor to risks of dementia. Some of that, so that it's not just because hearing loss leads to social isolation, leads to dementia, it's hearing loss itself. And some of that probably certainly does impact our ability to go and interact with the world and stay socially engaged. And not just socially engaged, but sort of mentally engaged. That you mentioned sort of listening to music to keep your brain sort of active and keeping those parts of our brain, right? That we think about music is a little bit different than speech, that like people can have strokes and have problems producing words, but can still sing, or can still dance. It's sort of like our bodies put memories in different places. And so keeping the parts that are about music and hearing bird song sort of active, it's sort of, you can think about like exercising that part of your brain like you'd exercise a muscle. So it's not just the social isolation, it's also the working to make sure that communication is there and that the mental activity can continue.
Got it. Thank you very much for answering that. Again, we have about 15 minutes. If you have any questions for Dr. Yoder, great time to get it in. So let's move to sleep. That was another, at the very top of the webinar, one of those key risk
Hmm.
factors. And it said less than 6 hours. And I want to ask two questions regarding that. If somebody is used to getting 6 hours or a little less, and that's sort of like that's what they feel like they need, and that's all they need, and have been that way for a very long time, are they going to be more at risk?
Yeah, another really good question. So these like numbers here and numbers with the drinking, like the excessive alcohol consumption for sure are averages. When we talk about we want to look at lots of people, take an average and get a best guess if we randomly pick a person, what's the threshold that we would want to use there. And that's sort of like one way that research, which is sort of a lot of my background, is kind of different than the practice of medicine, where with medicine, we want to look at the person in front of me. And like, it's very important to contextualize. Well, my wife is smaller than I am. And so the effects of alcohol on her are stronger than they are on me. And people differ in both their sleep quality, but also their need for sleep. So that someone who is fully functional and not suffering any of the negative effects of lack of sleep, maybe it certainly seems like some people are able to get along fine with 5.5 hours of sleep a night, that it's very difficult for them to try to sleep more. There's not some underlying cause that in almost everything about people, people are different and there's individual variation. And so that's why it's important to maintain sort of regular communication with like a primary care physician who understands your medical history. That medical history review and social history, all of that historical review in a care planning visit is so important to contextualize where someone's numbers might be. But we almost never want to take some measure and look at a single number and say, well, this is above or below, and so that tells us right now. We want to understand holistically what's happening, and that includes who a person is as an individual.
Got it. Thank you. And then continuing with sort of sleep questions. Does this also include circadian rhythm, prolonged circadian rhythm disruptions?
Yeah, absolutely. So the right, just poor sleep here doesn't have any of the sort of why is that poor sleep happening? Sometimes it's, people are having a glass of red wine a day, but they're doing it right before bed. That's going to disrupt sleep quality. Anything that disrupts circadian rhythms for sure is going to lead to other downstream consequences, and that's part of why these kinds of studies are so complicated is you have to do very careful statistics to tease those apart. But absolutely disruptions in circadian rhythms, any, like diseases or pathology in sleep quality would contribute to this poor sleep bucket.
Okay, got it. And then moving on to sort of diet, right? I mean, that's something that we can all control. We all control
Hmm.
what we eat, what we drink. And I'm curious, one of the keys there is sort of lowering inflammation. And, I know sugar is in just about everything that we eat and consume. It's hard to get away from it. And it's also pretty addictive. And it's kind of like, this is how we enjoy life. We like cake, we like cookies, we like these things. But would eliminating sugar as best we can, maybe be part of that sort of larger component of reducing inflammation, or what would be maybe the best thing somebody can do to overall lower the inflammation within their body, which would obviously not just reduce their risk for dementia, but would also help in many other facets, health-wise as well.
Yeah. I like that you use the word minimize rather than eliminate, right? Eliminating sugar is a bad idea unless there's like a separate issue. I think the sort of like there's been a lot of research, and it is true in my own life as well that the if you're thinking about changing diet and how you interact with food, it's often more about addition than subtraction. So rather than try to cut out sugar, it's add more leafy greens. There's something called the Mind diet. It's sort of a Mediterranean diet that there's a recent study that came out that's it really does seem to reduce the risk of cognitive health, and that's things like olive oil, lean proteins, so chicken, lots of, fiber, so get your beans, some nuts. Blueberries in particular seem to be really helpful. This study in particular sort of gave people a stipend to buy blueberries, and that group, along with all of the other things, had better health outcomes. They didn't have cognitive decline the way sort of a less structured intervention did. But that sort of like Mediterranean diet that you look for a balance of healthy fats, high fibers, so that's sort of your leafy greens, um, and where possible, trying to, really limit consumption of these like really highly processed foods. So like fried chicken, probably not every night. Um, and the 80-20 rule is something you might hear, that like 80% of your food should come from whole foods. So that's like, whole grains, broccoli, and not hyper processed foods. So like white rice sometimes is excluded, but and again, each person's a little different, so you can talk to a dietitian or work with your like a nurse practitioner or your doctor, whoever your medical professional is that you're working with, to help think through what's best for your situation. Obviously, someone who has gluten intolerance should be avoiding gluten, so there's not one solution, one size fits all, but the general suggestion for the mind diet works really well. So it's not necessarily about eliminating sugar entirely, but trying to find healthy sugar. So fruits and vegetables that are higher in sugar are totally great. Again, just blueberries seem to really pop out. Since that Sunday came out, I've been doing blueberry in my oatmeal in the morning, and it happens to be very tasty.
I do the same, and that's how I sweeten it. I just try
Yeah.
to stay from anything sweet, sugar-wise, but add the blueberries, and they make it sweet enough, at least for me. So I agree with you there. Um, so we have a couple more minutes. Again, questions for Dr. Yoder, if you have them, let's get those in over the next 10 minutes or so. When we talk about, you know, the risk factors and we talk about what dementia really is, as opposed to just normal um, you know normal memory loss, right? And I wouldn't say normal memory loss, but just like I forgot my keys, I forgot where these
Hmm.
things are. I forgot where I
Yeah.
placed something in the wrong place and I can't find it. um, if someone is having sort of the memory loss that you alluded to that might need some attention, is there a specific kind of health provider that someone should maybe go to first to sort of um, get the proper diagnosis right out of the gate, where they're kind of not wasting time, they're concerned? Do you have any options or any advice to give to somebody who may be presenting with dementia-related symptoms at this time, and where they should go?
Yeah, so the primary care physician is a good person to start with because the history. Again, the like knowing where someone's been, knowing that sort of background can be really helpful at ruling out things. It is not uncommon for primary care physicians to make referrals then to neurologists or neuropsychologists. That's where, if the cause is in the brain, there's a desire to sort of like really understand where things are. But if it's a mixed case and trying to understand, like, is there some brain damage that's leading to this, some sort of stroke or other kind of like lesion that might be happening, that's where like an MRI would be useful, and a specialist would might be called in. We do know that about 80% of dementia diagnoses happen in primary care settings. So a lot of people are going. Often, what happens is that someone will not go in for a memory complaint, and as part of sort of the normal interview process, then the memory complaint, sort of something seems a little bit off cognitively, and then sort of an assessment will happen after someone's had a fall, for instance. But just sort of being aware that cognitive health is something that you should be talking to your doctor about, and checking with family members. Also, it's like, hey, have you noticed anything strange in the last year or two? Those sorts of proactive conversations. And because it really is about change over a couple year period, that's the marker that something's starting to go a little off.
Got it. Okay, perfect. And the final question for me as we start to wind down here. So I know that there seems to be concerns, and this is just using as an example, for colon cancer that seems to be hitting people younger and younger and younger these days. I'm wondering if there's anything that has transpired over the last couple of years that has been concerning for people like yourself as it relates to dementia, maybe in terms of things that trends that you've noticed that sort of kind of come up that weren't there before, maybe a lower age bracket. Is there anything that you noticed on that and that you could share with our viewers here today?
Yeah, I mean, thankfully, no. I've not seen anything that suggests that age of diagnosis has sort of like gotten drastically lower. There are population trends that are going to lead to a higher proportion of Americans having dementia, but that's because we have an aging population. So there's sort of standard like incidence rates, which is sort of the first time someone's diagnosed, that increase as people get older. And so as the population in general gets older, we expect the prevalence, which is just how many people have the condition, to go up because there's a greater proportion of Americans who are 65 and older.
Got it. Perfect. This has been a great webinar, and I am super appreciative, and I know our viewers are as well, those who are watching here live, and then those who will be watching on the back end, for all of your knowledge and for taking the time to share it here with us. Thank you so much, Dr. Yoder, and please come back.
Well, thank you so much for having me, Vassell. It's been a real pleasure. Thanks again to Arbor for inviting us down to give this talk.
Yeah, thank you. And before we leave, one more time, can we give the information that people need to reach out if they want to be a part of your study?
Sure. Let me go. Again, if you are interested in participating, you can email us at info@sparkneuro.com.
All right, fantastic. And we'll leave that up here as we close this out. Dr. Yoder, thank you so much.
Thanks again for having me.
Thank you. Now, if you enjoyed watching this webinar with Dr. Yoder, we've got more just like this one over at our website, www.seniorlivinglive.com. There you can find videos all about senior living. You can watch them anytime. And of course, the best part, they are all free. Thank you so much for being with us here on Senior Living Live. Have a great day, everybody.